A very good evening. First of all, Dr. Shubham, thanks for giving me this opportunity to be here today. The first question that we need to ask is why screen for lung cancer? So in its localized stages, if appropriate treatment is given, lung cancer gives a 5-year survival of close to 60%. This drops down by half to 30% as soon as the regional nodes are involved and goes down to single digits in case of distant metastasis. Now, unfortunately, we see a very small fraction of cases in our practice which are actually in the localized stage. Next slide, please. The problem in India is also pretty grim. According to the Globocan 2018 data, the lung cancer incidence amongst males was 7.8 per 100,000 population, and the mortality was as high as 7.3. Coming closer home, in our hospital last year, we registered 2,400 cases of lung cancer. How many did we operate? Only 131. That's as low as 5.45%. So is it a significant enough problem for India? Yes. Is there a need for early detection? Definitely yes. Next slide, please. Does screening work? We have overwhelming data to tell us that low-dose CT screening in lung cancer definitely works. Two major trials, the NLST and the MILD, also in their long-term follow-up showed that screening for lung cancer with low-dose CT brought down not only lung cancer mortality, but also all-cause mortality. Next slide, please. Then we had this meta-analysis coming up recently in 2020, which includes all the major lung cancer screening trials with low-dose CTs, which also showed similar results. What it also showed was screening with low-dose CT actually increased the likelihood of picking up lung cancer at an earlier stage than usual care, making curative treatment options available for these patients. So maybe it is safe to say that screening definitely benefits the screened population. Next slide, please. Let's look at the IL-GAP data now. 31,000 patients screened with low-dose scans, 484 lung cancers picked up. 85% of these were picked up in stage 1, and all of these patients did exceptionally well, even better if they received timely treatment. So does it benefit the screened individual? That's a resounding yes. Next slide, please. So who is this ideal candidate who actually benefits from lung cancer screening? It is someone between 50 to 75 years of age who has significant smoking history, is currently smoking or has recently stopped, is in reasonably good health to undergo investigations and treatment in case of a positive screen, and importantly, someone who's committed to smoking cessation and to a prolonged screening. So the evidence that we do have right now is an annual low-dose CT for at least 3 years as per the NLST. The long-term follow-up of the MILD has also given us some evidence for a more protracted follow-up. Next slide, please. So all this is what is great about lung cancer screening with an LDCT, but it comes with its own set of caveats as well. We'll address the two most important ones, the false positives and the overdiagnosis. In the NLST, 40% of those who participated had at least one positive screens amongst the 3 scans that they underwent. Of these, a whopping 96% were actually false positives. These false positives got investigated further. Some of them were associated with major complications, including 11 deaths. These are staggering numbers, not something that we can take lightly. The second problem with low-dose CT was that of overdiagnosis. Overdiagnosis is when this intense screening picked up really indolent and slow-going tumors, which might not have really affected this individual's lifespan at all. Out of every death that the NLST prevented with 320 patients screened, 1.38 were actually overdiagnosed. Now, most of these patients have indolent tumors. They might probably have died of competing causes of death, being the heavy smokers that they already are. These caveats are important to consider because even in the Western world, where the evidence for low-dose CT screening is overwhelming, and most of it comes from the same part of the world, and even though most of the insurance companies actually covers low-dose screening for smokers, the acceptance rates are very low, It's as low as 14%. Now, the causes to this might be multifactorial. The problems in India are slightly different. Can we go to the next slide, please? So the average life expectancy in India today is 69 years, which is quite less compared to that we see in the Western population. So the 55 to 75-year age group that has been defined for screening might need to be rethought in the Indian context. 90% of the lung cancers in the Western world are actually associated with cigarette smoking, whereas in India, 40 to 50% of lung cancers occur in never smokers. So if we only end up screening the smokers, we might miss out on quite a few of these cancers. Thirdly, let's take a look at the smoking trends in India currently. The male smoking is actually taking a dip. It is the smokeless tobacco, which is a bigger menace. And we really don't have a definition of high risk in this population. Next slide, please. India is endemic for tuberculosis. Now, TB mimics cancer both clinically and radiologically. So, does TB have an effect on the efficacy of low-dose CT for screening for lung cancer? It might. Now, we don't have any hard data coming from India in this regard. So, let's look at a number of countries where tuberculosis is as big a problem as it is in India. The BELT trial was conducted in Brazil. The people that it screened had a similar profile to that of the NLST. In the first screening scan, positive results were seen as high as 40% in red, as against the 26% in the NLST, significantly high. But interestingly, the number of interventions in both these studies was similar. The authors explained this by saying that they had a very experienced radiologist who could actually differentiate between TB sequelae and suspicious nodules which deserve further intervention. But the caveat is, we did not have any follow-up on what happened to these positive scans with no intervention. Next slide, please. Then comes the K-Lucas study, which was conducted in Korea. It was a multi-center study with 11,000 participants. Now, TB sequelae was seen in 30% of those screened in their preliminary scans, quite a high number. What was seen in this trial was that the specificity of lung mass, which is what we use to actually read these screening scans, dropped significantly in patients who had TB sequelae. There was no change in sensitivity, but these patients had an increasing number of abnormal-looking nodules, which triggered a flurry of diagnostic intervention. Again, this is not something that is desirable in a resource-limited setting like India. Next slide, please. The third problem that we face is that of infrastructure. If we need to have a successful screening program, no doubt we need a greater penetration of LDCT facilities. Once the scan is done, we need an experienced radiologist to tell us what is benign, what is malignant, what needs to be biopsied. Then we need a good interventional radiologist who will actually target that lesion for us and give us some tissue diagnosis. And unfortunately, if it does turn out to be cancer, we need an oncology setup to actually deal with it. All of this depends on a very robust referral system, which as of today, India lacks. Next, please. Last but not the least, let's look at the cost implications. So this is quite an interesting study which came up in the NEGM, which looked at the cost effectiveness of using the LDCT in the NLST trial. And it showed that the expenditure for one quality adjusted life year gained was as high as 81,000 US dollars. Leave lung cancer aside, let's look at breast cancer, where screening has been widely accepted in the Western world, no questions asked. Screening for breast cancer, the government ends up shelling out $150,000 per quality gain. With 1.5% of our GDP invested into healthcare, can India really afford this? Next slide, please. These are all big problems, but there are a few potential solutions. First of all, we need to define an India-specific high-risk group. Probably have risk calculation models which factor in India-specific problems so that we can choose our patients for screening better. Secondly, we definitely need to find a solution for misdiagnosing TB and lung cancer. Maybe use parameters like volume doubling time might be more pertinent than the two-dimensional measurements that we currently use. Finally, we need to develop the necessary infrastructure. Maybe we can start using telereporting of LDCTs, make the expertise available even in remote areas. And we definitely need stronger referral systems, especially in cases of positive screening. Next, please. So there are a few things that we have to accept. We are quite far away from achieving all those potential solutions. Is India really ready for a national screening program today? I'd say probably not. But for all of us in our practice, do we see potential candidates who might benefit from screening, which might affect their mortality? Yes, we do. So we need to adopt a more practical and pragmatic approach, probably that of opportunistic screening. If we see an individual who fits the bill for LDCT screening for lung cancer, we have enough evidence to back us and go ahead with it. But we need to have a very clear dialogue about the potential benefits of screening as against the harms. And more importantly, screening needs to be offered if and only if we have the necessary infrastructure to actually deal with a positive screen if it is so seen. If not, we might end up doing more harm than good. Next slide, please.
Dr. Devayani, you have 2 minutes left.
Yeah, my last slide, thanks. So the last thing that needs to be seen is, does stopping smoking really affect the lung cancer incidence? Look at these graphs. There is a dramatic drop in lung cancer incidence, especially since the time from quitting increases. So maybe if India puts her resources towards smoking cessation, we might end up achieving our objective of decreasing mortality due to lung cancer more effectively than prematurely thinking of a screening program as of today. Thank you so much.